Hello, my name is Victoria Gonzalez. I'm an internal medicine resident at Wayne State, and today I'm presenting our quality improvement project titled ICU Transition of Care. To begin, here's a little background on our project. Transition of patient care from the intensive care unit to the medical wards has been identified as a crucial time for critically ill patients who are at high risk for potential harm due to medical errors. This is largely due to the lack of a universal standardized handoff process and communication. Previous studies have focused on the transition of care within specialties, particularly in the OR to ICU handoffs, shift-to-shift transitions, and care among house staff and resident end-of-rotation handoffs. However, the complexities of transitioning a patient from the ICU to the medical ward safely and effectively are less understood. This increased risk for adverse events is thought to be a multi-system failure due to the lack of standardization of communication, process, and policies surrounding ICU transitions of care. This quality improvement project highlights potential areas of weakness in the handoff process from an open ICU to the medical ward in a community hospital setting. In turn, our aim is to formulate a standardized transfer process by focusing on improvements in documentation and policy with an emphasis on communication. This will be in the form of a standardized handoff template to be utilized at the time when a critically ill patient is being transitioned from an open ICU back to the primary team on the medical ward. As this process does not exist yet, the goal is to utilize this new tool in at least 25% of transfers out of the ICU in the first month of its initiation. So for the methodology, initially the observation was made that there was no standard process which physicians and residents were following when handing off patients from the ICU to the medical ward. A root cause analysis was performed to identify areas of improvement in the handoff process. The persons involved, process, policy, and communication were identified as contributing factors in formulating a standardized transition of care process. On this slide, you can find the fishbone diagram that we use to identify causes contributing to an effective transition of care in patients from the ICU to the medical ward. After observing the need for this process to become ubiquitous, using the PDSA cycle, literature was reviewed and a transition of care template was formulated. During this initial PDSA cycle, after observing the need for this process and reviewing the literature, the handoff template was formulated with the goal to utilize this new tool in at least 25% of ICU transfers. Education was provided to internal medicine residents, faculty, ICU attendings, and the ICU committee. We studied the charts of all ICU admissions from November to December of 2019 to include as baseline data. 0% of them showed any summary of stay or handoff process on their last day of ICU admission. And then afterward, all ICU admissions from February to March 2020 were reviewed after the tool was introduced, and the data was analyzed for appropriate use of the tool and handoff process and compared to previous data. So for our findings, charts of all the ICU admissions from November to December 2019 were reviewed, which revealed that 0% of progress notes included any form of summary, checklist, or handoff documentation at the time of patient transfer from the ICU to the medical wards. After formulating the template, educating our users, and implementing its use in February of 2020, data was collected. Charts of 86 patients admitted to the ICU from February to March of 2020 were reviewed, and after 21 patients were excluded, 65 total charts were analyzed. Of all the cases reviewed, a total of 53.8% had documented successful handoff with appropriate use of template and provider-to-provider communication. There were 30 documented transfers which either used the template inappropriately or not at all and thus were deemed as incomplete patient handoffs. Our exclusion criteria can be found at the bottom. So, in conclusion, the goal of this quality improvement project was to use a multi-system approach to formulate a standardized transfer process focused on improvements in documentation and policy with an emphasis on communication to ensure patient safety. The success of this initiative was attributed to the original approach used and education, which in turn led to improved communication and ultimately a fundamental change in culture. One shortcoming noted was that residents working in the ICU from another program did not receive the same reinforcement in the education throughout the month via email reminders that the internal medicine residents did. In the future, a collaborative effort can be made to educate all residents together using the same modalities. Moving forward, this project can easily be reproduced at any SICE institution as illustrated in our study, by first evaluating the culture and process of transitioning patient care or lack thereof. This will allow for future projects to be developed based on observations gathered from this initial project. In implementing this new handoff tool, observations were made including the lack of a standardized medication reconciliation in the ICU prior to patient handoff, which will be the focus of our upcoming PDSA cycle moving forward. The ultimate goal remains the same, focusing on improvement in patient care by implementing a standardized multi-system process centered around safe and effective communication in the patient handoff process.